Welcome to the Hanley Effect, a podcast by the Hanley Foundation designed to educate, change minds, and save lives. Our goal is to inspire you, showcase our innovations, and change the conversation about addiction and mental health. Join us as we unravel stories of resilience, recovery, and hope.
Well, hi, everybody, and welcome to the Hanley Effect. I'm John Dyben.
I'm Rachel Docekal.
How you doing, Dr. D?
I'm good. How are you, Dr. D?
I'm doing pretty well. I'm, kind of trying to get over the cough and the crud and all that kind of stuff.
You have crud, and we may hear the cough during today's episode.
I'm gonna try hard. Actually, I've been a little anxious about it. Been feeling some anxiety about it because I don't want to ruin these things. And we have a really cool guest today.
Cool.
I'm a father of four. You're a mom. You have kids. We have adult kids, right? And so we've watched kids develop, and so anxiety and things like OCD and drive. These are things that we see affect our kids and our loved ones. And so I'm really excited today about our guest. We have Dr. Cali Werner, who is Ph.D., and she's also a licensed clinical social worker. And she has a really interesting background that goes way before being a clinician. And so we're going to talk about her background, her history, and some of these other topics that interest us.
And I got to see her in action. So recently, I was in Houston for a visit, going to see different centers and meet with different experts and specialists. And her center is a wow. It's a wow.
Well, we are wowed and grateful for you to be here. Welcome, Dr. Werner. Thanks for being here.
Thank you guys so much for having me. And likewise, I love everything that you all do and was so excited that we could have you in the flesh to come to our OCD Institute of Texas, but even more excited to just dive into some content that I'm really passionate about.
So can you tell us a little bit about what this concept is? What are we talking about? Tell us about the work that you do and whatever you can tell us about your story that brought you to this place today.
Yeah, so I have had OCD from the age of 3 onward. I just didn't realize or know exactly what it was when it onset. And I am a distance runner. So athletics are near and dear to my heart. And I started to get a lot of success in high school and college with distance running, cross country and track. And with that success, I tended to put a lot of pressure on myself. And that pressure really exacerbated the symptoms of my OCD, leading me to finally getting an appropriate diagnosis. I thought I wanted to be a sports reporter, news reporter when I was in college, and really evidence-based treatment saved my life and totally made me change my career trajectory to doing what I love now, which is during the day, I work at a residential facility, OCD Institute, treating more severe cases of OCD. And then I also have an outpatient private practice, Athlete Rising, where I work specifically with athletes that struggle with anxiety, OCD, and perfectionism, mainly because I just want people to get help earlier than I did.
So talk to us a little bit about, that line where regular anxiety that each one
Right.
of us has, crosses that line into something that really starts to affect someone's life.
Yeah, I think what the world says right now with social media and culture is that we shouldn't be experiencing anxiety, right? That we need to do all of these things like these quick fixes to get rid of anxiety, when in reality, anxiety is a part of being a human being, right? Like if we swerve somewhere or someone's swerving into our lane when we're driving, we get this adrenaline rush because we need to get out of their lane of traffic. And so really the goal of anxiety work is one for us to normalize it a little bit, but if it's taking more than an hour day out of your day and impacting your ability to function, then we know, okay, we might be meeting some criteria for an anxiety related disorder. which is totally different from the day-to-day anxiety that everybody experiences. And when we meet that diagnostic criteria, that's when it's really important for us to get the evidence-based care treatment from a licensed provider, and to be preventative so that it doesn't continue to get worse.
And I think about it as a parent. I'm wondering, when you, as a parent of an adolescent, who adolescence is filled with anxiety. How can parents help to really, first of all, how can they understand when there's a significant problem, but also how can we help develop our kids and our teenagers? How can we help them develop healthy anxiety as opposed to first of all, we need to recognize when they have the struggles, but also how do we help them when they do?
Have you guys heard of the book The Anxious Generation by Jonathan Haidt?
Yes.
It's a great one.
Yeah, it's one of my favorites because it really speaks to kind of what we've done in today's society with how we approach anxiety as parents. And one of the examples I think that maybe the book recommends or uses, he might have actually just said this in a social media post too, but is like when a kid goes to a playground to play now, let's say they fall off of a swing. Well, many parents' reaction to that is, "Oh no, we've got to remove the swing from the school. That swing was dangerous," right? Versus the actual appropriate way for a child to learn is, "I'm not going to jump off the swing when I'm swinging that high anymore," right? And instead, we take away
Right.
that
Right.
trigger or whatever it was that led to it. And so that's one of the things I want to teach parents is that anxiety is not dangerous, but in order for us to be able to really give our kids appropriate skills for how to tolerate and handle it, we have to let them experience some of it without immediately going to the rescue every time. Because in exposure with response prevention, the work we do that's primary gold standard treatment for OCD is we're trying to teach the individual that they can tolerate some of those feelings of distress. And so if the parent immediately removes that stressor from the child, they're sending a signal to that kid's brain that they couldn't handle it, that they can't experience anxiety, that anxiety is dangerous. And so it's really about jumping in and asking them to, well, wait a minute, what's the function of this behavior? But then, too, I don't want a parent to experience shame or guilt for responding in a way that remove their anxiety because most parents would respond that way, right? When we see our kid or our loved one struggling, it is human nature to jump in and make them feel better. And so it takes some coaching. I think it's really hard for the parents to just naturally know what to do when their kid is experiencing anxiety that is diagnosable, which is why that third party provider that sees the picture a little bit clearly from outside the circle is so important.
Visited you. And again, I can't say enough. Later in the episode, I really want you to talk a little bit about the work that you're doing there in your center because it's pretty remarkable. You drew a diagram on a whiteboard for me, and our listeners know I'm a big whiteboarder. I love to
Hmm.
I love to draw. But what you did is you talked through for me the compulsive pieces of it, and I think that the specifics that you were talking about with somebody who needed instead of self-soothing with something like cracking their knuckles or something, you were talking about needing parental reassurance.
Hmm.
So talk through that for our listeners because that was it just fascinating.
Yeah, one of the more common examples I like to use, just because I think so many parents can relate to this, is maybe a kiddo is going to bed at night and you've noticed, like with nighttime, your kid has more anxiety. And so they tend to want to kiss their parents goodnight before they go to bed every single night. And it's almost become a bit ritualistic. So they feel like I can't go to bed or I can't cope unless I kiss mom and dad goodnight, or unless mom and dad, come in and they tell me everything's going to be okay. Because I've had some patients who have a fear of, like young kids especially, what if something happens to mom and dad and I didn't tell them good night, and then I have to live with that discomfort, these types of things. Well, if the parent is saying, okay, yeah, one good night kiss, no big deal. But if we know that they're predisposed to what we call OCD, right? So obsessive compulsive disorder involves an obsession, like a trigger or a worry, that leads to a compulsion, like needing to kiss mom and dad goodnight in order to relieve the anxiety from that worry. Is it's only temporary, and we know that symptoms exacerbate the more we give into compulsion. So for this kid in particular, maybe it starts with one kiss at nighttime going to bed, and then they say, well, wait, can you come back and can I do it again? Can I kiss you goodnight again? Because that time it didn't feel right. And the parents come back and they kiss
Yeah.
them goodnight again. We know that we're toying with a little bit more of an OCD tendency here, right? If that symptom was something that took 5 seconds and it never really developed into anything, not reaching a diagnosis. But if it started out one way and now this nighttime routine has gotten more extensive, or parents are feeling like, I want to pull my hair out, I'm so frustrated, right? We know that they might be meeting more diagnostic criteria for OCD. And so every time that parent gives them reassurance, great, the kid feels better, but it's so temporary until the kid kind of has that what if thought, but what if that wasn't right? Or do I need to engage in that behavior again? Which just further exacerbates the OCD cycle. And so, exposure with response prevention, the treatment approach that we do, is to work on eliminating some of what we were just saying is reassurance, right? So the reassurance, maybe replacing that with what we call a supportive statement, which is includes a validating, confident type of comment, such as, hey, I know this is really hard for you, and I know you can do hard things. Remember, mom and dad said they were kissing you goodnight one time and they're gonna walk out, but we'll see you
Yeah.
tomorrow. Right. That is more effective than just giving into that anxiety every time for that kid and just sending the message that they can't handle it unless they do the compulsion.
Yeah. And I love that. I love
It's
and
so
you were talking about what a big piece family work is in the work that you're doing, because
Yeah.
unknowingly parents are feeding into this and enabling the behaviors, and in some cases making them worse.
Right, right. Yeah. And even what I would say as an OCD clinician who's done OCD specific work for over 7 years, if it were my own kids, I would still need somebody to kind of help keep me accountable, because when you're the one that's in it going through this with your child, you just don't see it as clearly as you would from someone kind of on the outside looking in. And I think that's true to all treatment, right? When you're the one struggling, your insight's not quite as there. And so, really helping parents to see that, yes, of course you would respond in that way, and we're not guilting you or shaming you for doing a parental type of response, but and what is this leading to long term, and how can we change some of your behavior so that your kid can develop healthy independence, and the ability to have long term freedom from anxiety.
It's interesting as I'm listening as a parent and a grandparent and listening, that was actually very helpful, because what I pulled out from that was, because everybody, we want to know, we want to do the right thing. How much is to, and what I heard, and tell me if I'm wrong, what I basically heard you say is, if comfort leads to requiring more comfort, then that's where you've got a problem. If
100%.
that's beautiful. That's so
Yeah,
helpful, I think, to parents.
yeah, it kind of reminds me, I'll go back to my own sport performance, right? There's some research that I've done that I'm really passionate about, on superstitious behaviors in sport. And most research shows that when an athlete engages in a superstition, it leads to more confidence. This research study that I did with a good friend of mine who's a sports psychologist, we evaluated superstitious rituals in sport, anxiety levels in sport, and burnout in sport. And what we found is that athletes that are predisposed to anxiety, those superstitions actually hurt their sport performance confidence. So they're not helpful. And a perfect example is,
Wow.
I have this predisposition for OCD, right? It's a genetic, we know that there's a genetic component to it. We don't know how much, but I started off in my races needing to tie my shoes multiple times because I felt like I had to get this just right feeling in order to feel good enough to win my race. And I had a lucky number 4. So let's say I usually just tied my shoes 4 times. It never turned into anything else. I'd go win my race, and we just knew that Callie tied her shoes 4 times before race, no big deal. Well, I had the predisposition for anxiety and OCD. And so it started off that way. But then when I would win that race, it would be, oh, okay, well, I tied my shoes 4 times and I high fived this teammate and I listened to this pregame song and I used this shampoo in my hair that, and so I need to do all those things as well. And so it starts off as this 30-second ritual that became this onerous multi-hour ritual that of course would lead to burnout with me lining up to the starting line of a race.
And when I think about, I know you treat all sorts of people, adults and kids, and you've worked with Olympians and high performers, and you personally I mean, you have a history even into adulthood and of extremely high performance athleticism. You know, it's I wonder when I think about kids who are really high performing athletes, it must be more difficult in my mind. It would be more difficult to tell the difference between, OCD and just a kid who's really super high performing. Because man, I think about the kids I've known that are committed athletes, and they are. It is like an obsession. How is that more difficult for parents to see when there's a problem?
Parents, absolutely, right? For an OCD clinician that's gone to school and done a lot of training to know the difference between perfectionism and OCD, not as much, but I also think even perfectionism, like what we're describing as type A personality, or when type A personality kind of goes to this extreme, that alone also might need some treatment, right? And so it's really about kind of asking, okay, is this sustainable for this child long term, right? So if I have a kid who has, well, first let me explain difference between OCD and perfectionism. That might be helpful. So someone with OCD and someone with perfectionism might both want to do something before their game. Like they might both, let's say, keep their bag orderly and tidy before, with all their clothes in it, with their uniform maybe perfectly folded before their game. They're bringing that backpack to school and they want everything in it to be nice and tidy. The difference is, let's say the individual with perfectionism keeps it really neat and tidy and folds it. The individual with OCD keeps it really neat and tidy and folds it. The individual with perfectionism likes it that way. They're like, I function better this way. I enjoy it being this way. Other people should probably have their bags folded just the way that I do. The individual with OCD has a fear that if I don't do it this way, something bad will happen. If I don't have everything in my bag folded correctly, I'll lose this performance or I'll perform poorly. They don't want to be engaging in that behavior. So, first, I think we have to know if it's one or the other. When it's perfectionism, also, is that treatment, or is that interfering their ability to function, or is it going to interfere? Like if they're able to manage right now, but we know they're in third grade baseball, and baseball stakes only get higher as they get more intense. Is that sustainable for them if they're hoping to continue to play long term? If not, yeah, then we probably do want to target some of those perfectionistic behaviors, and help them develop a little bit more flexibility, because usually an athlete that's struggling with perfectionism at that level also has a really hard time tolerating mistakes. And we know that mistakes are inevitable in sport performance, out of sport performance, in the classroom, whatever it may be. And so we really want them to be able to, one of my favorite quotes is, the best athletes aren't the ones that make the fewest mistakes. They're the ones that learn to bounce back quickly from those mistakes. And so we really want them to be able to learn how to tolerate those better.
Yeah. Tell us a little bit about the residential facility where you work. Start by letting our listeners know, when would somebody need inpatient care instead of working on an outpatient basis? And then just talk about length of stay and all those different components.
Yeah, of course. OCD Institute of Texas is located in the Houston Heights area, uh, kind of smack in the middle of the city of Houston. Our director and owner, Elizabeth Mackingdale, is oversight of the program, and her story is all over online. Very powerful story about her own struggle, which led her to doing this work and becoming a clinician. And we know that for intensive treatment, one, residential means they're living here, right? So they're staying with us in the program. We also have day programming, which is 5 days a week where they're here from 9 to 4, but they go either, if they're in the area, home after the treatment day, or stay at an Airbnb nearby with family. And then outpatient level of care, we also have, that's where you're meeting with a provider once to twice a week for 45 to 50 minutes. And really, what a few different things that we can determine entails a need for residential is, how have you been doing outpatient, and have you not been making progress, right? So outpatient, they should be, if they have a diagnosis of OCD, really be engaging in what we call exposure with response prevention. It's a form of cognitive behavioral therapy. And if they have been meeting with a provider doing this ERP work, we really should see that in about 4 to 6 sessions, they start to make some leadway, that they are starting to improve, that things are getting a little bit easier. And if not, one of the questions that we are asking is a higher level of care needed? When we're determining the difference between day programming, like do they just need to come in for the treatment day, or residential, the big indicator is, are there a lot of family accommodating behaviors? So if so, you can imagine me asking a patient to, hey, let's work on some, we'll say, use contamination OCD, some exposures around contamination where we're touching some items that you find contaminated in our residential program. But they go home and their family accommodates all their symptoms by giving them a bunch of reassurance, by washing things for them after
Mm.
the treatment day. That's not going to be super effective. So we might want them to start off residential with us so that we can educate the family and them on how to appropriately respond to OCD without accommodating. And so that would be a good indicator that there's a need for residential. Also, some patients come residential because they need to get back to their life quicker. Um, we know of something called postpartum OCD, and mom might develop postpartum OCD after having her baby, and maybe she comes in to us 5 to 7 weeks after being postpartum. Well, that mom needs to get back to her baby as quickly as she possibly can. So a more extensive course of treatment through residential probably get her back to doing that a little bit quicker. So there's a few indicators, a few factors. Our average length of stay is about 10 to 12 weeks, and that includes if they step down from residential to day programming. And it's amazing. I love the work that we do because we really, before our eyes, get to see patients get their lives back that weren't able to leave their homes, or that were taking multi-hour showers, or that were so terrified they couldn't even go to work anymore. So it's really, really rewarding work.
Amazing.
It is amazing. I'm wondering, we think a lot about, people who suffer with this their whole lives. Do people ever, like later in late adolescence or adulthood, who have not had a history of this, do people develop OCD and these disorders in adulthood?
Great question. Yeah. So we know the primary ages of onset of symptoms are like the big life transitions. So, for example, we see a lot of people develop an onset of OCD around the time they transition from high school into college. They're on their own for the first time. That's a big life change, or really during any big life stressors. Parents get a divorce, they're moving from one home to another home. So you can really see onset at any point in time, including late adulthood. Sometimes we have patients in their 50s or 60s that develop an onset of OCD for the first time ever, and come in for treatment. I would say the most common ages, though, are that like 8 to 12 age range, or 18 to 21 age range. We see the most around those times. Yeah, like myself, my symptoms started at age 3. But I didn't get an appropriate diagnosis until I was 21, and that's also super common. I think average amount of time it takes from onset of symptoms for someone to receive an appropriate diagnosis of OCD is still about 17 years, according to the research, which is a problem that we still need to
Wow.
work on.
Wow.
Wow.
That's incredible.
That's 17 years. That's a lot of suffering needlessly. Uh,
And
Go ahead.
well, I'm just wondering, during that 17 years, is the disease flatlined, or is it something that gets progressively worse and that's why it's finally noticed?
Yeah, great question. We know that symptoms tend to wax and wane when OCD, like for example, or life gets more stressful, right? So for me, until I got that diagnosis, my OCD, we would always see a peak around cross country season or around race season, because for me, racing was a big stressor and I didn't have the appropriate coping skills. And then off season would come into play and it would come down a little bit until that, say, the switch flipped, until it didn't matter anymore if I was in season or not. My symptoms had gotten so bad that I couldn't turn it on and off. And I think that's what we tend to see with time is we know that when left untreated, OCD worsens with time, but there are periods in a child, adolescent, teen's life where it gets worse and it gets better, but usually there's a point where, okay, that waxing and waning isn't happening anymore, and now we need to get them effective treatment. I would say, though, if any parents are listening, don't, if you notice that, okay, well, it's only bad during their basketball season or whatever it may be, we can just get through that. And it's so much better to get the preventative skills ahead of time because you're saving your kid from having to get to that point where it reaches the point of exasperation or complete debilitation, and they can get better much quicker if we can do that preventative work.
Makes sense. Makes sense.
Makes total sense. And, I think sometimes people are afraid to, to bring their their child to a therapist or a specialist because there's this fear of, oh my gosh, they're going to get this diagnosis and it's going to follow. But as I hear you and just, what I hear is that you're looking for how you can help kids develop skills so that things don't get worse in the future.
Yeah, two things I would say about that. One, we know that I often will have parents ask me, should we just not tell them there's a diagnosis? What if that follows them, or is that something that's going to lead to a lot of stigma? And one, the worst thing we could do is not tell them what the diagnosis is because the kid stays confused and has a really hard time identifying what is their OCD and what isn't. And so when we can name it, I always say it's a CBT term, but if we can name it, we can name it. And so if they can give that OCD a name, they're able to actually separate themselves from it. Quite the opposite of what the parent's fear is, right? Oh, that's OCD, and this is how I treat it, and I know I have skills for it. Two, I have a lot of parents ask me, well, should we just take them out of that fill in the blank thing that's triggering them, sport, class, or whatever it may be? And my answer to that is absolutely not. Because we know that when that kid develops another passion, the OCD is just going to move to that. And so the goal is really to give them the skills to learn to tolerate the distress with whatever that stressor is that they're facing so that they can continue to love it. Or maybe afterwards they decide that they don't love it, but that's a values-based decision, not an anxiety-based decision.
Love that.
So I'm just curious, and this is sort of a funny question, but how would you explain to our listeners the difference between a true OCD diagnosis and individuals who compulsively look at their phone all day, looking for a text, looking for an email,
Whew,
and I this is John
that
knows
hits
this
home.
because,
Yeah.
we both know people who cannot put their phones down and
Yeah.
check it constantly.
Yeah. Well, I know, so for OCD, the most common measure that we use at our clinic is the Yale Brown obsessive-compulsive scale and symptom checklist. And so if you look at that symptom checklist, it's about 50 to 60 symptoms long, and you can determine if someone has OCD or not based off of that, as well as the severity scale at the end. And what I would say is most people, if you go through that symptom checklist, because it is so long and extensive, would be able to check off one or two of those things. But that does not mean that they have a diagnosis of OCD, right? So is it taking more than an hour out of their day or their ability to function? That's a big indicator that they probably would meet diagnostic criteria. We do see phones used as a form of a compulsion in OCD often now, and it's not great, or a form of what I would say distraction. So when someone is feeling distressed, our goal is in OCD treatment, we say the term ride the wave. Have that patient ride the wave where the anxiety goes up and it naturally starts to go down instead of doing what they used to do, which was, for example, I touch this contaminated item, I feel really distressed, let me do a hand wash, and their anxiety immediately goes down. Well, if someone is, let's say, doing an exposure of touching that contaminated surface, but then they immediately pick up their phone and start scrolling to distract themselves, that's also them not riding the wave, right? Using that as a form of distraction. They're telling themselves, I can't tolerate or I can't feel the anxiety. I'll
Right.
use an example of some of us might be able to relate. Like I get on an elevator and maybe it's crowded and I don't really want to talk to other people on the elevator. My personal natural inclination is to pick up my phone and look down, right? When I'm on that elevator.
Right.
And the message I'm sending to my brain is that I can't tolerate the distress of being here with these other individuals. Now, is that debilitating for me? No, I could get on an elevator and I could stand awkwardly and I could be uncomfortable until it's not at a point where it's a problem. But I think what I would ask listeners is, can you go without having your phone for that meeting or for that hour? And if not, if your distress would be too heightened, okay, well then we do have a problem and some anxiety work that needs to be done.
I love that.
Love it. Well, I hate to say this, but I have to be the bad guy
I
again.
know.
I'm
He's
always the
always the
bad
bad
guy.
guy. I
I
get
am the
to be
bad
the
guy.
good guy.
We are at the end of our time. Dr. Werner, this has been fantastic. Thank you so much for all of this information. We like to let our guests also have the last word. So thinking about the people that are listening, there's families, clinicians, there's all sorts of people. What is one last thing that you would like to hear, you would like our audience to hear from you today?
Say that freedom from an anxiety disorder does exist. So I can confidently say I spent many hours doing my own rituals and compulsions when I was younger and when I didn't have appropriate effective treatment. And I can honestly say that probably over the course of the last 3 months, I've had maybe one OCD intrusive thought at this point. And so, evidence-based treatment does work. We are, as human beings that live in today's society, going to experience anxiety, but it shouldn't be something that we have to suffer with. And so if that's the case, if this anxiety is truly a definition of suffering for whoever is listening, then get appropriate evidence-based treatment. You deserve better.
Fantastic.
Love that. Dr. Cali Werner, thank you so much. Dr. D, thank you. This has been a blast.
Dr. D, this was terrific today. Thank you. I learned a
Fantastic.
lot again.
Especially as a parent, I'll tell you.
Yes.
Thanks you everybody for tuning in or for listening. We'll see you next time on the Hanley Effect.
Bye, everyone.
Thank you for joining us for the Hanley Effect. To learn more about our programs, visit hanleyfoundation.org or call 844-502-4673.